Welcome back to piyushmalik.com. Today we are going to discuss stellate ganglion block, how to do it and who should be doing it. In my opinion, every anesthesiologist should know how to do it, and they would be better helping the chronic pain physicians, those who do not understand or are not very proficient with ultrasound. Stellate ganglion block is also called a cervicothoracic sympathetic ganglion block. What is the indication? The primary indication of this block is to perform and to treat sympathetically mediated or maintained pain, otherwise known as reflex sympathetic dystrophy, causalgia, or complex regional pain syndrome type 1, and mostly the newer term. Now, rest of the indications can be for other chronic pain modalities. People have used it successfully for hypohidrosis of fascio-axillary or palmar hyperhidrosis. Post-traumatic stress disorder has been included in the recent past as a very important resolution of this problem, and refractory cardiac arrhythmias. The patient who has having VTAC and ventricular tachycardia in spite of all your treatments. How to do it? This is the position of how to do it. What you are seeing in the ultrasound screen is a flat line below the carotid artery. We'll level it, you'll get to know. Probably this is the C7 level. Now, let me tell you a little bit of anatomy of stellate ganglion block or stellate ganglion per se. It's formed, it's a cervicothoracic, both basically C7 and T1, where the at that level where those stellate ganglion lies. The length can be up to 0.5, zero point 0.5 half a centimeter to 2 centimeters. Some book says 2.5 centimeter, but you don't see it. It's a flat triangular. Sometimes they say it is wedge shaped. So basically, even in ultrasound, probably you don't see it, but what you see is the longus colli muscle. Okay, the structures you need to identify, these are the must thing you should do prior to trying this block. Where is the esophagus? Inferior thyroid artery, vertebral artery and vein, anterior and posterior tubercles of the Chesniak tubercle of C6. That is the anterior tubercle, which is a very prominent, we'll see in the next slide, and C7, which do not have a anterior tubercle, which is rudimentary. So basically C7 is flat. So if you put your ultrasound probe over C6, then you see this tubercle, the very angulated, and uh, it's like a sharp nail sort of thing going up. So it is C6. Suddenly, if you pull the transducer a little bit below, it disappears. At the C7 is that's how you identify the space or place to inject your drug. So we'll be doing this block in between C6 and C7, thinking that it will trickle down below C7. So this is a very important step to identify the anterior and posterior tubercles of both this vertebral level. Phrenic nerve, sometimes it is found mostly at the anterior surface of the medius or anterior skeleton muscle. And the most important thing above all is the longus colli muscle, which sits over the transverse process over the C6 and C7. Okay, this is a C6 transverse process, sixth cervical vertebral transverse process. If you see this is the vertebral artery, See it again. This is C6, and we came down a below. Now seventh, it's written 7 transverse process, which is flat, and C6 transverse process, which is a continued upstairs. Up there is a sharp upgoing. Okay, so C6 and C7. The redness over there with the Doppler is the vertebral artery and vein, carotid artery, and most important is longus colli muscle. And upstairs in the top of the picture, you are seeing the sternocleidomastoid muscle. So C7 vertebra is flat. Again, C7, this is C6, C7. So C7, what is labeled here, it's completely flat. So our aim is to deposit just above the longus colli, that LC which is written. This is the thick muscle over there, you are seeing it. You bring your needle at the top of the muscles and inject and deposit your 5 to 15 ml of local anesthetic with or without steroid. All right. So above the longus colli muscles. Some book says you can, the stellate ganglion might rise below the fascia of the longus colli muscles, that is below it, and some says that it is in the fascia, and some says it is above the fascia. So this is how you do it. This is the longus colli muscle. Now we will be seeing, so what you are seeing, C6, this is C7, here it is C6, C7 again. So I am just for demonstrate, this is C6 and the flat line, this is C7. So the carotid is beating, sternocleidomastoid, longus colli muscle. C6 again, you see that angulated thing is going up, and this is where the C6 is not visible in the flat one. The flat one, here is the flat one, this is C7 level. In this level, you are going to give the block. Let's see the block proper now. All right. So this is the needle coming. This is a flat line. So that means we are at the C7 level and we'll start our block. Needle is coming through the anterior scalene muscle, and I am somewhere there in the muscle, in the longus colli muscles, much below its fascia. So it is almost intramuscular, right? In between the muscle I am trying to give. But if you see carefully, this needle which is looking like intramuscular, it is actually at the end of the or upper surface of the longus colli muscles, where is post superior lateral is the you see there is something, the needle is going below a artery or vein like looking like structures. Actually this is the phrenic nerve. Later on we did find out. You try to avoid phrenic nerve. Most of this is the vertebral artery now beating. Okay, so what I will try to do is to deposit some of the drugs there, avoiding the phrenic nerve, not injuring it. All right. Okay, so there is some drug is deposited inside the muscle. The next video you are going to see, I will try to go above those phrenic nerve, or it might be due to recurrent, it might be a recurrent laryngeal nerve. I am going at the top of this to the superior surface of the longus colli muscle. Can you see it? Try to appreciate. Now I am going to deposit some of the drugs there. So endpoint, what you are going to see is the Horner syndrome. Immediately after finishing up the block, the eye becomes, the side of the injectant will become red and voice will become hoarse. The recurrent laryngeal nerve and and some patient might have some difficulty in breathing. So that is why you don't do a bilateral stellate ganglion block. All right. So this is the needle position over the longus colli muscle. You don't see the stellate ganglion. All right. And thanks for watching it.